I have just joined in the Department of Health Informatics in Bangladesh. Actually, this is the only health informatics department in Bangladesh that is giving academic courses, and I have just started working in it, and I'm looking forward learning every new things. And my personal interest is in mobile health because I feel this could be the next major thing where we can start working in this developing area.
Okay, thank you very much. Abu Buyan from Bangladesh. He is a faculty from the Department of Health Informatics of the Bangladesh University of Health Sciences. Thank you very much. How about Albert? Do you have a microphone with you? And could you please introduce yourself to our meeting room?
Yeah, yes, I'm Albert Pratama from Yogyakarta, Indonesia. I am a health information system developer. Together with my team, I developed specialized HIS for public health center in Indonesia.
Okay, thank you very much, Albert. Albert is one of our good friends in the Asia eHealth Information Network. I would also like to tell everyone that Albert has given a local webinar session for the Philippines just yesterday. So we also have our speaker, Chuck. We just have a 1 minute audio check. Hello, Chuck. Could you try speaking on your microphone? Hello, Chuck. Hello. 1, 2, 3.
1, 2, 3. Can you hear me now?
Yeah, that's better, and that's great. I can hear you now.
All right, sorry, I had to adjust the microphone level there.
Okay, thank you very much for that audio check. So we're still working with your audio. I will have some introductions with our meeting room. Here we have next is we have a while ago Dr. Clive. Dr. Clive, could you try introducing yourself?
Yes, of course. Hello, hi everyone in the meeting room. I'm Dr. Clive. I'm also a medical professional. I have also done my master's in health informatics, and I am now attached to the management, development, and planning unit of the Ministry of Health in Sri Lanka. And also, my special area is standards, and we are trying to develop a standards framework in Sri Lanka as well. Thank you.
Okay, thank you very much. So Dr. Clive is from Sri Lanka. How about Jar? Do you have your microphone? Could you try speaking and introduce yourself to our meeting room?
Hello everyone, my name is Zar. I'm the head of operations for a French multinational company here in the Philippines, and we're actually involved in laboratory information systems. We do a lot of interoperability with analyzers and HIS systems. So it's actually my first time, so I'm really interested in learning. Thank you.
Okay, thank you very much. Jar is from the Philippines. Thank you. I will now go to Rajiv, who is raising his hand. Rajiv, could you introduce yourself to our meeting room before we start?
Hello.
Hi.
I am Dr. Rajiv Joshi. I am a pediatrician practicing from Pune in India. I'm working in health informatics for last 20 years. I'd like to learn how to use mobile interoperability in mobile. Thank you.
Okay, thank you very much, Dr. Rajiv. Dr. Rajiv again is from India. We go now to Monica. Hello, Monica. Go ahead, Monica.
Hello. Hello.
Hello. Go ahead.
Hello.
Go ahead. There we go. We can hear you.
Yes. Hello. I'm currently a student of health informatics here in the Philippines, and I just want to know more about mobile health and interoperability. interoperability. And I hope that I can learn a lot from this webinar.
Okay.
That's a good evening to all.
Thank you very much, Monica. Monica is a student from the Philippines of De La Salle University. Thank you very much, Monica. We now move to Rizwan. Rizwan, could you introduce yourself? And we have a...
Yeah, hello. This is Rizwan from Bangladesh. Can you hear me?
Yes, very clear.
Okay. I'm currently working with the GIZ as a junior advisor for the health information system, and working with the city corporation here in CNET to develop their urban health MIS system. And looking forward to know more about the mobile health and interoperability today. Thank you.
Okay. Thank you very much. Rizwan is from Bangladesh and a very good friend from GIZ. Always very active in the Asia eHealth Information Network. We move on to Surayo, who is the earliest from all of us here. Go ahead, Surayo, introduce yourself.
Hello, good evening, everyone. I'm Suraya, and now I work for University Medical Center Groningen in Netherlands. I work for a project for telemonitoring system for elderly, but I'm originally from Indonesia and from the university, same city as Mr. Albert from Yogyakarta. Now I'm doing my PhD here in Netherlands as well. Nice to meet you.
Wow.
Thank you.
Nice to hear from you, Surayo. He is from our region, but it's not what you mentioned. So I think we are very well attended this evening here in the Philippines. I would love to have my introduction first before I give the floor to our speaker. But first of all, I would like to thank every one of you, and most especially our speaker, Sir Chuck Parker, for really making this 18-hour for mHealth for interoperability. So, good evening from here in the Philippines. This is Aliyah Evangelista from the Asia eHealth Information Network. Welcome to this month's 18-hour, our network's online learning and sharing session that happens every second Wednesdays and fourth Fridays of the month, 3 p.m. Philippine time. But tonight, we are very happy to have this very special 18-hour on this time slot, 7 p.m. for our topic on mHealth for interoperability. Today is September 11, and it's exactly 8:40 Philippine time, and we have with us today Sir Chuck Parker of Continua Alliance as our speaker for the topic mHealth for interoperability. Some very quick announcements before we start our session. We are now using Cisco WebEx as platform for our meeting. And if you are encountering problems on your connection, just log out in the meeting room and rejoin immediately. And your mic will be mute during the rest of the meeting. And if you have questions, you can type it in the chat box or either click the raise your hand button on your screen to raise your question directly to our speaker. So far, our connection is very good from my end and from your end, and I hope we will be able to maximize discussion within our group. We're only a small group of participants, and I hope that we could share our knowledge and throw our questions to our speaker. And after our meeting, do not forget to accomplish the evaluation survey, which I will be sending to you right after this meeting. And once you accomplish it, I will be sending you more information, readings, and other resources on our topic today, including where you can find and share this webinar recording. And lastly, as what we do usually in our AVR, we stand by and have our photo taking session at the end of our meeting so we can document our virtual presence in our AVR, and we could tell our network and colleagues of what has happened in the next, what has happened to this AVR. So if you are ready to participate, let's start the session by knowing more of our speaker. So our speaker for this evening here in the Philippines is Mr. Chuck Parker, who is the Executive Director of the Continua Health Alliance, a membership-driven company focused on developing an ecosystem of interoperable personal health devices. Mr. Chuck Parker leads the many working groups and day-to-day operations of Continua Health Alliance. He has over 20 years of experience in healthcare technology, policy, and the strategic design of evaluation and measurement strategies, and has led national programs for practice transformation and has served on national committees for assessing adoption requirements. Thank you so much, Mr. Chuck Parker, for really waking up very early for this 18-hour, and I know our network is so excited to have your presentation for this evening. So without further ado, I will be transferring you now to Mr. Chuck Parker. Hello, sir. Chuck, go ahead.
Yes, thank you very much, Aaliyah. I appreciate that, and thanks for the introduction. I just want to do a mic check, make sure everyone can hear me. If you can't at this point, please indicate that whether or not you can, or just make sure that I can hear you. Can be hearing me at this time. All right, thank you. So at this point, I'd like to go ahead and start the presentation, and we'll step through some of the details here of what Continua does and how we are working on an international scope to focus on this interoperability issue, and that is to ensure that mobile devices, and these are devices that we would carry not only from a handset perspective, but also device architectures such as glucometers, spirometry, weight scales, thermometers, and how we actually are able to use those today in a much more unified approach with individuals at home, work, or play. Next slide, please. All right. So what is personal connected health? Let's talk a little bit about what it is that we mean and how we define that. We changed the term, we don't use the term mHealth in Continua because mHealth has a designation of being a mobile capability, being mobile within the organization. And that could be anything from a tablet in the hospital to facilities that actually may be in ambulances. So what we use is the term personal connected health. This is information that's gathered about the individual, in and around the individual, and for the individual. So we call it personal connected health. How do we link the individual back to the healthcare system? So this is really communications and healthcare devices deployed or enabled by healthcare organizations to collect and share individual patient physiologic and quality of life data. Unlike telehealth, it allows patients and providers to employ data communications independently. What this means is that this is a nonlinear approach. Typically today, with telehealth applications, you have to have a video communication link, and there has to be someone set up at both ends of the link, viewing each other at that time. What we have here is, and within our systems, it's a nonlinear approach, meaning that the individual can collect the data at their own convenience, let's say in the morning when they get up, and then the provider can read that data whenever they feel like they need to within the workflow of their day. So they can take a look at that in the morning, in the afternoon, or whenever that information is most convenient for them to process. It also allows us in a nonlinear approach to apply analytics to this data. Since we can collect the data and then actually do some analysis on it, we can then present the data to providers or to extended caregivers that may be working with the individual with some analysis to that to give them indications of what the individual may have or may be doing. So it allows us to create a nonlinear approach to medicine and allows us to do analytics on the data as well. Some examples of personal connected health are remote home monitoring programs in chronic disease or independent aging. So this is really truly taking a look at how do we want to monitor individuals who have, for example, diabetes, congestive heart failure, COPD or asthma, or individuals who are living at home who are aging independently. We want to keep them there safe and well, so we want to ensure that we're doing that appropriately. Also, the personal connected health allows providers and patients to use the technology to collect the data conveniently and securely. I think that's an important part of that, is that it is the model does provide a high level of security for transmitting the data. It can also allow us to communicate more frequently with little manual intervention, which means that I don't have to take a blood pressure reading from a blood pressure cuff, then have the individual either call or manually enter those numbers into the system. Just as when you've taken the blood pressure reading, that information then automatically begins to flow into the system. So it allows for much more convenient and, as necessary, makes it more robust and easier to use for the individual to collect that data, and less error prone significantly, because now we don't have them either translating errors or perhaps manually entering information incorrectly as well. So what are some of the drivers behind this particular model, and why are we seeing this in the market space begin to move today? Well, there's certainly pressure on the healthcare system these days, regardless of where you are in the world today on costs. What we now know is that it's much easier and much more cost-effective to treat an individual at home. We want to make sure that they can stay home longer. We want to make sure that they can return home quicker because their quality of life is higher there. And so what we're seeing here is a drive to move the individual out of the healthcare in the hospital itself into a much less costly environment, whether that be into a long-term care facility, back home, or working specifically with the physician office. We're also seeing a demographic change pushing this model too with an aging population. We now have populations in some countries who are predominantly, let's say for example in Japan, where the predominance of age is actually now individuals who are at retirement age. So we're now seeing a push towards how do we manage this population more effectively, and how do we keep them safe in their homes. There's also an increase worldwide on chronic diseases and a desire to manage those chronic diseases, making sure that we can keep the individuals where they are healthy. And what's interesting is we start to see, while we're not actually introducing a Western diet, it's a Westernization of the way foods are processed. And as a result of that, we're seeing increasing activities with obesity as well as with diabetes. And these disease states now then lead to much longer long-term care issues that require us to have significant investments in the healthcare system if we cannot control or monitor or manage these diseases more effectively with the individual at home. Are also seeing a significant cost in healthcare expenses themselves, and finding a way to manage those individual activity overall so that we can manage the chronic disease and long-term illnesses much more effectively. And then ultimately what we're also seeing, and this is also a global issue, is the provision of healthcare. And that is that we're seeing less and less a number of doctors per individual patients who are coming to see and be within the system today. We simply don't have, and this is even true within our highly medical communities today that you see in the Western side, like for example in the US, but also in developing nations as well, for example in China, where we just simply don't have enough doctors or healthcare providers to cover the number of individuals who may be coming to the healthcare system. So we need to find new ways now to monitor and measure individuals and provide and use healthcare information technology on the analytics side to be able to manage these populations more effectively so that we can utilize the resources of our healthcare professionals more effectively. So what are some of the benefits of personal connected health today? Well, for the patient or the consumer in this case, they remain or return home much quicker, so it improves their quality of life. Their time is also better spent because now they're at home instead of stuck in either in a hospital room or in a long-term care facility. There's also significant cost savings to the overall health system for the individual. There's also a new awareness of the health status because now they're getting feedback on a daily basis on what their healthcare condition is. And they can actually then learn how to take steps more effectively because they see that information more on a real-time basis. There's also improved collaboration with their healthcare providers so that they're now seeing the overall impact and can communicate with their provider. In this case, it can be a physician, it can be a nurse, it can be a healthcare professional who's trained to help the individual with a specific disease state. But it improves that collaboration because now they have a linkage between the two that can provide real-time data to the back-end systems. And ultimately what we're seeing is that it can provide an avoidance of unnecessary office visits and or emergency room visits. Because we're able to monitor the individual, we can see the trends happening much faster. And because we can see the trends, we can do something about them quicker and prevent those unnecessary office visits and or emergency room visits. From a provider perspective, it provides automatic updates and alerts on the patient status. It also provides an improved triage capability for preservation of those physician resources or medical resources for the more serious cases. So in essence, what you have here is the ability to triage cases to ensure that you're only elevating those that are at the high risk to the right level of provider in the organization. And it certainly provides you a maximal time for preventive action because now we can see the trend begin to happen and we can actually begin to tweak with either medications or modifying the lifestyle or diet at that point with the individual, and provides an ideal way to manage chronic disease management today. So some of our for things that we take a look at here and why is this important and why we see the value of interoperability come into play here today. We have very clear examples of why interoperability works and why it is actually of benefit to the community at large. Cell phones are one example of that. With the advent of the GSM chip, we now have the ability to use a cell phone on multiple carriers. And as a result of that, it drives down the cost overall of expensive technology such as smartphones, so that we now began to create commodity type of applications on our commodity type of devices that allow us to provide a significant amount of intelligence on an easy to use basis. This also is true with the ATM, which is the automated teller machine network for retrieving funds. Not only now can I retrieve funds inside my own country, I can very easily acquire funds regardless of where I'm traveling in the world today, and actually use the ATM network relatively easily to acquire cash or other transactional needs on a monetary basis. So simply, when we take a look at interoperability, it provides ease of use, freedom of choice. There's a higher degree of user satisfaction because there is that choice. Provides a level of innovation. A significant component of this is that it does provide scalability, and overall the cost becomes much less to manage on an overall basis. So, Continua Health Alliance. We are an international not-for-profit organization enabling end-to-end plug-and-play connectivity of personal connected health devices and services, and a service called Personal Connected Health. We have more than 200 members organizationally throughout the world. They come from the technology side, the medical device manufacturer side, telecom industries, health technology services, and healthcare industry leaders. In addition to that, we have many governmental provider organizations who also participate with us throughout the world as well, to focus on this and understand what's going on with interoperability, as they are, in most cases, the drivers of healthcare within their specific regions of the world. So what do? We develop and publish design guidelines that combine and apply existing standards. No single standards body today actually can achieve the end-to-end interoperability required from taking information from a device and carrying it all the way back into the medical record on the back end. So what Continua does is create a set of guidelines that integrate today currently 9 different standards bodies work into an interoperability model that allows you to connect those devices, pass that information into a hub, which in this case could be a smartphone, could be a personally something like a smart TV, could also be a device that's actually there in the home as a purpose-built hub, and then have that information collect from one or multiple devices information about the patient and transmit it back to the back-end system so that it can flow into an electronic medical record, a personal health record, or as necessary when it's in a larger context, a health information exchange. The design guidelines specifically define how you implement those standards today, how you integrate very specific activities from an IEEE component, and able to pass that information into, for example, an HL7 messaging stream format. So the design guidelines specifically detail how you integrate the standards, and where necessary, we profile down or constrain down the standards, the underlying standards, so that you can surely achieve interoperability. For us to achieve interoperability, sometimes you have to make tough choices, even with the underlying standards, to ensure that you have, at that point, a model that you can be assured will connect. So in some cases where there's perhaps a may in the guidelines, the underlying standards, the guidelines will require shall and or we actually make a selection if it's an A or a B type of an output. We also then certify product systems and services for compliance with those guidelines. So the only way that you can certainly ensure that you have interoperability is to apply some level of compliance testing to ensure that those devices, services, components have all met those requirements for compliance and the guidelines themselves. We also here to promote a favorable operating climate for personal connected health through advocacy and coordination. So not only do we work on the aspects of the standardization, we also work on a policy basis locally to ensure that we are removing any barriers to adoption within local governments, also advocating specifically for these types of technologies with local governments, and then where necessary, beginning to form regional work groups to ensure that the communities are put together locally to begin to initiate communications amongst the healthcare providers, those organizations like telcos, device manufacturers, and governments, to ensure that we can foster an adoption model and an adoption coordination within a given market. And ultimately, we also look at connecting the technology developers, innovators, and healthcare organizations within the community as well. So we do play a matchmaking role within Continua to link organizations who may be small developers in, for example, in China, with large companies who may be in Europe or in the US, so that you can actually find ways to link technologies together more effectively and robustly spread the ability of the market to grow. So here are some of the things that we take a look at here from the standards and incorporated in the design guidelines today. So as I mentioned, we're working with many different standards bodies, but here are some of the underlying standards that currently are comprised within the guidelines today. So we're using IEEE, Bluetooth, USB, Zigbee. The W3C, which is Worldwide Web Consortium, is our security model that we use. And we work with IHE and HL7 on the back-end systems to integrate the data into electronic medical records, personal health records, and health information exchanges. One recent addition to this model here has been NFC. So now we have the ability to use NFC as a transport from a device to the smartphone, for example. So breaking down the interoperability chain here, what we're doing here is ensuring that we can get information from devices all the way into what we call the aggregation manager or aggregation hub. And I'm sorry, my build's not working here. I'm trying to get it to advance. There we go. And so what we take is from the device architectures. So we have 15 different device classes defined today. Those include things such as thermometer, the pulse oximeter, peak flow meters, insulin pumps, independent living activity monitors, as well as simple things such as blood pressure cuffs, weight scales, and glucometers. We are continuing to add additional devices into the architecture. Continua is a living, the guidelines themselves are a living document that get updated every year. And so as we begin to continue to move forward, we can add additional device architectures. An example of that is there is work currently going underway right now for sleep apnea and adding additional devices that can monitor individuals with sleep deprivation or sleep problems. The devices then flow through a specific transport, whether it be Bluetooth, USB, or Zigbee, into a hub. In this case, the aggregation manager. A hub can be a smartphone running an application. It can be a specific box that has been purpose-built. It could be a smart TV running a Java app on the smart TV itself. But however you approach it, it's a user interface that then collects the data from one or multiple devices and then presents it back to the end user. And then on the back end of that, then creates a package that can it formulates the data into an HL7 messaging stream that can then be handed off into the back end systems for personal health records, electronic health records, and transfer that information securely using SAML 2.0 security models. In this particular designation, we show the information flowing from the aggregation manager directly back to the personal health record. But that information can also flow to a telehealth service center, so that if you have a critical care monitoring that you're doing with an individual, let's say it's a congestive heart failure patient who's just come out of a hospital, you may have the individual collecting that data, but have a telehealth service monitoring that information because of the criticality of that potential patient to ensure that they are surviving correctly. And then the information can flow on back into the permanent personal record of the individual. So it allows for some flexibility in the way that you actually establish and monitor and create a model by which you manage patient populations in this case. Like I said, we can use smartphones today. We can use hubs today. So it depends upon how, and here again from a flexibility perspective, how you would like to integrate the data, how you would like to, what is best used by the individual. Some of our elders are not comfortable using smartphones, so we may actually have a relatively larger screen device that's set in the home so that they can actually interact with it. So here again, the model does provide flexibility while ensuring interoperability of the devices and information flow from the device all the way back into the back-end systems. So why interoperability? Well, compliance with global industry standards is proven to decrease time to market and also reduce development costs. We've already proven that it lowers design costs. It's saved in some cases anywhere from $40,000 to $80,000 in development costs per device. This was information that was gathered on a multinational level. This is not specifically the U.S., just that the figures are listed in U.S. dollars. Allows you to get faster to market because there's a decrease in integration time from 3 months to just 3 weeks. And a point to note here is that Continua, in and of itself, one of the benefits that it offers its members is a wide set of developmental code. So we have something called the Continua Enabling Source Code Library that any member can use and download and rapidly prototype against a device, service, or hub that allows them to create and rapidly manage and develop device architectures. It also provides increased efficiency, so it's quicker, less expensive integration into EMR HIE platforms. This was also proven out recently in about a year and a half ago, and I'll actually have the use case here pop up here towards the end of this case. But the efficiency of being able to bring this to market was proven after the Japan earthquake and tsunami. We also have something that's unique in the market space too. It's very unique, but it's something that's new to the market space, and that is that we allow forward and backward compatibility with devices. Once you have an interoperable device, even though it's maybe a version 1, because it still has met that interoperability requirement, it can continue to be used in systems with later revision dates. So it allows you to bring forward older devices and have backward compatibility with some of these device architectures to ensure that you don't lose your investment with each change of the guidelines. And ultimately what it does, it allows you to have easy to expand or add new programs and products with plug-and-play capabilities. So while I may be initially monitoring an individual who's come home from the hospital for, let's say, for example, diabetes, and I'm managing them with a glucose meter and a blood pressure cuff. I may also want to add a weight scale and a pulse oximeter depending upon what I see from their outcomes. I can quickly add additional devices to these systems to add additional features and monitoring capabilities to the individual. So how do we get there? How do we actually achieve what we do today? So there's an open process in developing design guidelines for Continua. We are driven by a use case process. So we've taken, define a use case, and that is, what do you want to achieve from a use case? I need to achieve monitoring sleep apnea overnight for an individual on a mobile basis. We then write the requirements up for how that use cases then should be established. And once the requirements are written, then we use our technical working groups to go through and define and look at and decompose those and match those against existing standards bodies and standards work sets that are out there. Where necessary, we will actually go back and work with standards bodies to improve the underlying work. We've done that several times throughout the course of the 7 years of Continua recently. One of those was an example of working with Bluetooth. The original Bluetooth stack was not secure enough to meet US and EU requirements for data transmission of medical data. So we went back and worked with the Bluetooth work group to help them understand what this actually meant, and actually then created the health data profile, which is a Bluetooth profile that is now required for transmitting medical data on a Bluetooth-like format. Since then, since we now have created that, the newer versions of Bluetooth, Bluetooth Smart and Bluetooth 4.0, all include the security requirements that were defined at that HTTP process 3 years ago. But just is an example of how we actually can go back and work with the standards bodies to improve their underlying work to ensure that we have achieved the requirements of security as well as compliance. Once the requirements and we've selected this underlying standards, we then write those into guidelines. And we have created a set of guidelines that are then released on an annual basis. These guidelines are freely available to any organization, any individual who would like to download them. There is a request form on the website, and it's just a simple, you fill that out, and we will send you along the guidelines. The reason that we do that is that we want to ensure that we can provide you updates and notices when we have errata and bug fixes. throughout the year, as well as when we release a new schedule or release a new set of guidelines. The guidelines then drive at the end of that the ability for us to create a testing model and a testing process. And at the end of that, we actually then are able to test for compliancy perspectives whether or not the devices can operate and achieve the ultimate data flow that is required from the device out into these underlying back-end systems and services. So this is a model by which we have effectively then deployed our guidelines. Like I said, we're now on our 5th version of the guidelines that will be coming out shortly as well at this time. I seem to have lost control of the presentation. I can't at this time advance it. I don't have the ball any longer. Aaliyah, can you? So the individual who is Cirlino, could you pass me the ball? Oh, thank you. I appreciate that. So how does interoperability support mHealth? It enables convenient, robust data exchange, facilitates large-scale data sharing, meaning that we're now able to collect much more data than we have in the past. Simplifies the consolidation of the health data from different sources in this model as well, because now you only have a single channel that you have to collect, plugging into electronic medical record. You only have a single channel that you have to, an interface that you have to create to collect now information from 15 different device types. Promotes a positive user experience because now they're not having to worry about connectivity. They don't have to worry about setting up that connection, ensuring and making sure that there's special ways to tweak an individual device. Basically, all devices would operate the same way in connecting. Introduces new flexibility for launching and maintaining home health and consumer personal connected health as well. So, for example, same-use devices are interchangeable. So if I like the user interface of blood pressure A from another company rather than the one that was given to me, I can simply change those out and know that I will be able to collect data and still have that information flow effectively. So where are we going today? Globally scalable products and services in personal connected health are where we're focused on this today. We are now working with national adoptions that are already underway in Denmark and Singapore. Denmark was the first country to actually specifically require continual compliance with devices. And the reason for this is that they are in an advanced healthcare information state today. They use a significant amount of healthcare information technology in their overall processing. And what's interesting is that they are now at a point in their systems where they're looking at actually reducing or closing a number of hospital beds as they redesign their healthcare system. They see the benefit in actually keeping the individual at home, and as a result of that, need this type of technology to ensure that they can not only monitor that individual, but also provide an experience by which they can now effectively manage the disease state at home. We're also seeing regional adoptions by Abu Dhabi, the NHS out of the UK, which is the National Health System of the UK. And in addition to that, there are some significant commercial deployments now taking place in Japan. We're also working with government adoption too. In this case, we're taking showcases and where we're experiencing, creating an experience for a government to see how these devices can actually be implemented. We take in essence, a showcase of devices. It's actually relatively easy because these are mostly small devices that can travel and package relatively easily, and we can demonstrate, 15 to 40 different device types and styles in these demonstrations. We do have an expanding presence right now in China, India, and Australia. We're developing new work groups in Brazil, Southeast Asia, and the Middle East. And I think this work group, or this group here, might be most interested in knowing that our Southeast Asia work group is having a formal kickoff on October 23rd in Singapore. I'll be able to provide the Secretary here a little bit more information about what that actually means. But we're creating, as I mentioned, one of those local focus work groups in the Southeast Asia work area. We also have an increasing reach here with global standards and coordinating bodies. An example that we'll actually talk about here very shortly is with the ITU. We also coordinate very closely with organizations such as WHO and the UN foundations to ensure that they are now looking at how they can use standards in deploying demonstration projects in low-income areas. Where are we today and what are we doing here today? So these are the areas that we're working in across the globe. The ones in red are already adopting Continua or using it today in deployments. And then we have Continua work groups that are now focused on these particular specific regions as well. As I mentioned, we're now working closely with the ITU to incorporate Continua design guideline standards into an ITU formatted activity or action item. And what will happen here is that the Continua guidelines will be referenced within the ITUT versions here, which allow us then to create and have any country in the world reference Continua standards as an international standard today. So it allows then any governmental body to reference these specific underlying standards and procurement requirements. We also provide an open source initiative here today as well. So we're fostering an open source initiative through something called openhealthtools.org to publish open source code covering all the Continua end-to-end interfaces. We've put some code out there in the open source community and also are taking contributions now from other companies to, in essence, provide demonstrations of how this actually can be integrated together today. So we are fostering, though, and encouraging open source developments as well in this personal connected health ecosystem. As I mentioned earlier, there is a case study that took place here recently in Japan with the tsunami and earthquake. Post-tsunami and earthquake, there were many refugees who were displaced from their homes, many of whom were over the age of 55, and as a result of the earthquake, had no access to their medical records. So inside the refugee camps, we were able then to rapidly deploy a set of, in essence, kiosks. These are device architectures that were put together to monitor just basically things such as weight, blood pressure, pulse oximetry, and where necessary from those that knew they were diabetics, glucose, and capture that data. So we were able to put that together, and here, because of the ability to actually deploy it, it was less than 2 weeks. It actually was only 10 days for us to assemble the devices and ensure that we actually had connectivity on the back end. So it only took us roughly only relatively short amount of time to deploy this, and the overall cost was significantly less than the non-Continua systems that were deployed in other refugee camps. So we're able to, in essence, here demonstrate that we were able to bring down deployment time by a sixth, and we saved over 139,000, this is US dollars, in that deployment. But more importantly, we were able to begin serving individuals more rapidly who were in critical need of being able to be monitored in this case. And as a result of that, we showed a 14% improvement in the camp that had the Continua equipment in place earlier than in the other equipments, the other refugee camps. There's a 14% improvement in overall health outcomes and identification of diseases that were critical in nature that needed further follow-up for the individual. So what this means is that because of the plug-and-play nature, we were able to deploy the technology, drop it in there, have it up and running, and be able to start capturing data from a critical set of patients rapidly in this market space. So that's the full presentation I have today. I want to present that to you and let you know a little bit about some of the things that have been going on. I will cover a little bit more about the fact that we are, as I mentioned, having a Indian work group as well as a Southeast Asia work group. We have been active in participation in the area. Continua has an active and ongoing relationship now with Singapore in looking at how we can deploy in that specific market space. And then from there, we're also working with other interests, national governmental body interests in the region as well. Continua does have programs throughout the globe. We actually do participate, for example, with the EU, European Commission. We're actually funded for projects for the European Commission. We work directly with ministries of health throughout the globe and are at this point looking at how can we carry that international standards capability into developing worlds and developing nations as well. With that said, I'd like to open it up for questions if there's any questions at this time.
Thank you so much, Chuck. So as he has said, the floor is now open for your questions, your clarifications. Any question? We also welcome in our meeting room Dr. Samantha Wimlaratne from Sri Lanka. Any questions now? So I have to ask a question. So as a network, we're really looking forward on how personal healthcare devices could work well with the innovations that each country are creating now. So just my question for you now to just start the ball rolling is that how can AHIM maximize the strength of Continua, knowing that you already have a pool of 100 of technical experts on interoperability?
Well, I think that there are a couple of things that we do. We want to encourage organizations to participate with Continua, become a member, and you have access to the community at large. It allows you to gain access to those resources as well as the Continua resources, like I mentioned, some of the development code if you're interested in that. But more importantly, it allows you to link to other companies that are inside the alliance itself. That's one way to take advantage of it. Another way is that we encourage you to reach out if you have an interest. We certainly can link you with companies or organizations that are in the region who are resources in that particular area. We have 6 test houses throughout the globe that have, each one of them have a certified expert, a continuous certified expert. We have additional experts through some of our other resources as well that can help define and help you understand how to implement this technology if that's something that you're interested in as well. I think from a perspective of actually from a governmental body, we encourage outreach to that capability too, so that we can explore how to integrate these technologies, integrate this specific model as well into the back end.
Thank you so much. What I pick up there was that AHIM could work together on the standards and requirements that it wanted and be able to present this to Continua Alliance and present this to vendors so that they would see the actual needs of the region. So we move on to another question, which I saw a while ago. I saw Rajiv Joshi, who was raising his hand. Rajiv, I'm unmuting you. You can ask your question now to Sir Parker.
Hello.
Hello. Go ahead, Rajiv.
Yeah. I wanted to ask whether the Continua Alliance would be certifying software developed on mobiles.
We certify the interoperability of the devices on and the services and the software at that point. So we certify that the applications that are on mobile platforms can correctly collect the data from a device, and on the back end be able to, and then certify that it can actually transmit the data in the required formats to transmit to an electronic medical record. We don't actually, we don't test the user interface. We just simply test the interoperability components.
Okay. The second part of my was, have you any time in the past tested or certified incoming messages in the system? I am asking this because most of the applications people are using ordinary phones rather than smartphones. So we are developing application based. We are developing application based on incoming text messages.
Okay,
ordinary mobile phones.
Could you re-ask the question? You broke up right as you were asking the question. It broke up really bad. There was some background noise.
So should I ask again?
Yeah.
Hello.
Yes. Can you please ask again?
Yeah. I assume that the application that you are testing are on smartphones.
Yes,
have you tested any applications on ordinary mobile phones?
Yes, we are working in. Really, we can actually integrate with any mobile phone that can achieve and connect with an IP address and actually display a web browser of some type. So it's in this case, it's not a requirement that it has to be a smartphone. It's obviously easier if it is, but any phone that has and can connect to an IP connection on the back end can be usable in this particular model as well.
Okay. Okay. Thank you.
Thank you so much, Rajiv, for your question. So we move on to Dr. Clive's question now.
Yes, thank you, Aliva, and hello, Mr. Parker as well. Thank you. I don't know if I missed this. Can you just clarify the exact version of or the CDL HL7 that you all are using, or is it mixture of everything?
It is a depends sort of a situation. The primary component of HL7 that we use is version 2.7, but
Okay.
we do use we are transmitting and are transferring to HL7 3.0 when we take a look at how do we use the consolidated CDA architecture as well as some of the back-end capabilities. So there's a certain level that we had to meet today, and that's 2.7 for the majority of existing solutions today, but we are migrating our work to 3.0.
Okay, thank you very much.
Okay, that's it. As discussed, the HO7, the Continua Health Alliance, is using 2.0, and did I get it correctly?
It's actually 2.7.
That's 2.7.
Right. The oldest version that we're using is version 2.7, and there's some.
Okay, and now there are some work
there's
going
some
on.
Right, and then we're moving to the XML-based version, which is HL7 3.0.
Okay, thank you so much. Dr. Clive, do you have another follow-up question?
Just a small one. This is on the peripheral side for the devices that you're mentioning, the thermometer and all that. Are they got to be IP6 sort of compliant, or you're still on IP4? Hello?
Hello, hello, Chuck. Are you still there?
Yes, I'm still here.
Yeah, my question was. Hello,
I didn't hear it. Was there a question asked? Because I did not hear that.
Yeah, I'm Clive here. This is regarding your peripheral devices, right? Your pulse oximeter, your thermometer, which are capturing data. Hello, can you hear me? Hello, can you hear me?
Yes, go ahead. Dr. Clive, I'm typing also your question.
Yeah. This is regarding the peripheral devices. Are they? Is there something like they have to be IP6 or IP6 compliant, or is it just IP4 is enough?
Hello, I think we're having problems on Sir Chuck Parker's end. But I have the question is, on peripheral devices capturing data, do they have to be IP6 compliant?
That's right. That's right.
So
yes.
I hope you can hear me now at this point. No, they don't have to be IP6 compliant yet. It's IP version 4.
Okay.
We are and have and can accommodate IP6 today in the architecture, but they are not required to be IP6 today.
Oh, thank you very much. Thanks. That's all. Thank you.
Okay, so that's it. They don't have to be IP6 compliant, but they're IP4 compliant. So any other questions from our meeting room? Let me hear from Dr. Samantha. Dr. Samantha, are you there? Hello, do you have questions to our speaker?
No question, because I understood most of the things. We are working on these things. Thank you.
Okay. So, any other questions from our meeting room? Maybe from our friend from Indonesia? Ever? Okay. So, there's another question here from Albert. I think Albert has having problems with this audio. How do you manage the data collected from the devices? Do you have a certain application framework to be used, or do you build a custom application for each country or area?
In this case, it's the information that's coming in is going into an electronic medical record most likely. So there's a repository that may be required. There may be a repository that's in collecting the data. Those are somewhat country specific, obviously, because there are, in essence, generally rules on how health data must flow within a given population for a given country. So they tend to be country specific, but we are capable of transmitting data to any open standard or any electronic medical record, any personal health record that follows the HL7 standards for accepting CDAs, clinical data architecture, clinical care documents today. We are also able to transmit directly into systems, older systems that may not have that capability, but can accept an HL7 message stream today as well. So we're not limiting in that nature. We specifically try to work with, and understand what are the profiles for a given specific country or a specific healthcare entity, and then help to make sure that we create that model. But the repository of data tends to be at the facility. It tends to be a back-end healthcare entity. It tends to be a physician office. It tends to be a governmentally owned system of healthcare records that we're transmitting to in those cases the endpoint. In some cases, though, from a consumer basis, we are now working with personal health records for individuals who want to monitor and just simply are interested in caring for themselves. Something called the quantified self. These are individuals who know that they may have a history of, for example, pre-hypertension, and start to want to manage the disease state themselves, so they can connect into personal health records and manage the information themselves. And then where necessary, they can then allow a physician or a practicing provider to have access to that data as necessary when they see fit. So these are all models that we've used today. The backend systems, we don't create the backend systems. We hand off data in a very well-defined format. Like I said, those defined systems tend to be governed by individual local rules.
Thank you very much. Dr. Clive, do you have another question? You're raising your hand.
Because I think I had to lower my hand. Sorry.
Okay. Okay, so that's it. If more questions coming in from Jar.
Yeah, just a quick question, Chuck. Thank you, by the way, for the presentation. I'm just trying to really understand what the Continua Health Alliance is really offering. So first, I'm trying to differentiate it between. This might sound silly, but I'm trying to differentiate it between IHE. Like, what's the difference between IHE and Continua Health Alliance?
Okay, so IHE really governs the inpatient, in-hospital types of systems. So we work very closely, we're tied very closely with IHE as an example of that. So where they are managing the inside the patient, inside the acute care facility, we're managing the outside of that capability. So we've sort of partnered together, and what we do is we manage device information coming in from outside the facility capabilities. So we work very closely with them. We are very similarly aligned. They focus on the inpatient systems, and in most cases also in some cases the provider office communications models, and we focus on the outside. So we have a very close working relationship in that manner.
Okay. Just as we all know, HL7, even though it's currently a standard that's widely used, it's also subjected to interpretations. So people just don't use. So correct me if I'm wrong, but Continua Health Alliance actually helps set certain guidelines so that everybody interprets certain fields the same way. Is that how it works?
Exactly. That's what we're doing today.
Understood. Okay. All right.
Yes, that's exactly what we do. So we get the different device manufacturers and organizations like healthcare and the consumers, like the NHS out of the UK, who's consuming this data. We get them together to agree to those standards, and then define them very specifically so that they now have one specific model that they're developing for us.
Okay, understood. That's about it for me. Thanks, Chuck.
Thanks, Jar, for that wonderful question. Actually, IHP has presented here in our 18 hour last, uh, I think it's May of this year, and we're really happy that we're now looking in more and more organizations and networks working on standards and interoperability, so that we will be able to, so that our region will be guided on how to implement systems. So, any other questions from our meeting room? From Rizwan of Bangladesh. Hello, Rizwan.
No, currently I don't have any questions. Thank you.
Okay. From Sorayo. Hello.
Yes, hello. Actually, my question was already asked what the mobile phone application for the. I am just interested to know how the continuous support or the interoperability for the application itself. How can I get resources? What I'm interested to build that kind of application in the future.
Okay. Thank you.
Yes.
Go ahead.
Yeah, so I just wanted to a further explanation is that we make it easier for the device app, or the app manufacturer in this case, to collect device data in a standard format, so that you don't now have to create custom interfaces from an application to a device. You don't have to write specifically down to, for example, the Bluetooth stack to ensure that you now know that how you're capturing that data from a device. We make that much more agnostic, make it much easier for you just to understand that data is going to come in a certain format and look like a certain format, and it makes it easier for you to understand how that data is going to come in. And then we define specifically how the data needs to go out, so it's one common interface that you program the data going out to.
Okay. So thank you very much, Sir Chuck. Any final words to our participants in our 18R before we close and have our photo taking session?
Sure. Just one thing I'd like to say is that I think there's some great synergy that we have here as an organization with you and the organization there. We have really shared interest in regional and national adoption of health IT. We have a dedication to interoperability as it means to improve healthcare. We have interest in policy and regulation to support market development there locally as well. And we have a commitment to open standards to ensure that these are open and available to all, and that is something that's easy for implementation. And we have a strategy to promote stakeholder collaboration in those areas as well, so that we can ensure that you don't end up with proprietary and vendor lock-in type of solutions in this case as well.
Okay.
So I just want to say thank you very much for the opportunity to speak with you all today.
Okay, thank you as well, Chuck, for really waking up that very early in the morning. We're so happy to have you and share with us what is mHealth for interoperability, and most especially to learn what Continua Health Alliance is doing and how we could really maximize your strength to the benefit of our network. So before we end, I hope we will now go to our photo taking session. Could you open if you have a video with you, I invite you to open your video and just have this photo taking session. I saw Samantha, Rajiv, open your window. Chuck, if you have one, so that we could take and report to our network that we had our 18th hour. So that's it. I saw Rizwan, Sorayo, very early in the afternoon in Netherlands. We also have Jar. The Jar doesn't have a phone. Monica, Craig James. So, okay. Just have it supposed to be we still wait for Rajiv and the others. We can report it to our network. So 1, 2, 3. Smile. Thank you so much for that wonderful smile for our A&R session this afternoon. I hope we could see you all next time on our next month, 18 hour. This is Aliyah Evangelista from the Asia eHealth Information Network. Don't forget to sign the evaluation form that I will be sending to all of you. So see you again next month for our next session of the 18 hour. Bye. Bye. Thanks, Chuck.
Thank you.